Thank you, Dr. Jacob, and thank you for the kind words. The topic given to me is, should we use biological DMRDs and targeted synthetic DMRDs early in autoimmune rheumatic disease? If yes, when and where and how? So I'm going to touch upon few autoimmune diseases today: rheumatoid arthritis, spondyloarthritis, psoriatic arthritis, that is inflammatory arthritis group, and lupus and vasculitis. And I have to admit that we all rely so much on technology. And today morning, when I was about to download my presentation into my computer froze at 8:30. Then I sat and did the entire presentation in 2 hours and came here. Just by excuse and shake, I couldn't join you in the beginning. So sorry for my simplistic slides. The slides are in the frozen computer. The central tenet of treatment of autoimmune disease is inflammation multiplied time is damage, and damage is permanent. So this is the most important tenet, because that is the urgency of treating any autoimmune disease as early as possible to prevent damage. This is true for any disease. If you have an uveitis, if you don't treat it adequately and appropriately, you may end up with complications like post-acinic, cataract and glaucoma, etc. Same in a patient with psoriasis or a discoid lupus erythematosus. If the treatment is not started appropriately, it can lead to permanent disfiguring scars. So damage is permanent, so entire endeavor is to treat early, identify patients early, treat and treat adequately, and continue to treat and remain in suppression, keep the disease in suppression. And one more interesting concept which had come is treat to target. Earlier we used to give treatment and just rely on the patients saying us whether they are getting better or not. Now we have a target for most of the diseases, and we have been ambitious from a specialty which gave only tender love and care. Not long ago, 2 to 3 decades ago, I'm sure some of the seniors here, they would not, rheumatoid disease means only aspirin and probably corticosteroids, and even corticosteroids came up in late 50s. So before that only aspirin, tender love and care and massage and probably hot water therapy. So from that stage we have become very ambitious. We have now remission as a goal. So though cure is elusive, and I have to stress that it's not only the rheumatic disease which don't have a cure, except infections, no other disease is cured. Either they are self-limiting or chronic. So back pain, nobody cures it, your body heals itself. And rest of the diseases like asthma, diabetes, hypertension, they have to be managed similar to rheumatoid arthritis and rheumatological diseases. So the target has been a remission or a low disease activity. So what is the standard of care at this moment in rheumatoid arthritis? Still the early diagnosis, early beginning of a treatment, and conventional synthetic DMRDs like methotrexate is still the drug of choice. And what we have learned over time is we don't waste time with methotrexate 7.5 milligram for 3-6 months and 10 milligram for 6 months and waste time. And because by this time the inflammation has persisted in the joint and has become chronic. So we have learned to rapidly escalate the dose to 20 to 25 milligram once a week. And if they don't respond, then quickly add other DMRDs like sulfasalazine or hydroxychloroquine as a part of a triple DMRD therapy or leflunomide, and try to achieve a quick control. And is there a merit for introducing more expensive, within brackets, more powerful biologicals and antisynthetic drugs early in rheumatoid arthritis? There have been studies to look at this hypothesis, and surprisingly our conventional treatment in a patient with biological or DMRD naive patients, an early rheumatoid arthritis patient, and whether we use aggressive therapy along with that any biologicals, the difference has been very small. 40 to 50% of the patients are able to achieve our target with our regular conventional approach. And only adding abatacept seemed to tilt the scale towards the biological usage as an advantage. And so conventional treatment helps in majority of the patients, at least not majority, 40 to 50% of the patients who achieve a good control. This percentage keeps increasing if you treat them early enough. If you have a patient with 3 months rheumatoid arthritis, you can achieve a larger proportion of patients achieving a remission. Vis-a-vis patient who has 1 year duration arthritis, because the percentage of patients who are able to get control very well with conventional disease modifying drugs becomes 30% or 40%. So conventional treatments are effective, and methotrexate is still an anchor drug. Only couple of drugs, JAK inhibitors like tofacitinib and tocilizumab and etanercept has shown to be superior to methotrexate as a monotherapy when it is begun in a biological naive patients. And we have learnt about the efficacy of methotrexate only after the arrival of biologicals. When they tried to compare, then we thought that biologicals are very effective, but head to head they are only as good or slightly better than methotrexate as the when they are tried as head to head. But because we have treatment to target as a strategy with low disease activity or remission as a target, and we have strong, vast experience with conventional disease modifying drugs of almost 2 to 3 decades now. So its safety and efficacy is very well established. We know what it can do, what it cannot do, what harm it can do. So we still advocate using the conventional synthetic DMRD as a first line therapy. Is there a role for targeted synthetic DMRD in biologicals? Yes. When the disease is very aggressive, it is as a part of your treat to target strategy. I will come to it a little later. So when you have an early arthritis, particularly patients with disease activity is high, multiple joint swellings, rheumatoid arthritis, CCP or high titer positive, this type of patients we can use combination DMRD upfront. We can use steroid and methotrexate, or we can consider giving biological DMRD with methotrexate relatively early once your initial 2 to 3 months trial of your conventional DMRD is failed. In otherwise low disease activity patients who have number of joints are less, functionally they are doing well, we can consider, we have to go with your conventional disease modifying drugs. These are the few studies to say that in a comparative trial, etanercept and tocilizumab have performed slightly better than methotrexate monotherapy. Why biological DMRDs and tofacitinib are not still the first line of therapy? The reasons could be biologicals are still expensive. It costs at least 15,000 rupees a month. It's unlikely to go down below this in the near future. And we need to screen them for infections like hepatitis B, tuberculosis before we initiate these drugs. And also we need to evaluate a type of patient. If you have a patient who gets admitted, history of 2-3 admissions for a UTI and upper respiratory infections to a hospital who requiring IV antibiotics, this is self-selected patients who are not going to do well when you immunosuppress them. So we need to probably be a little more cautious in using biologicals in them upfront. And side effect profile, they are reasonably safe drugs. We are not going to scare you from the concept of biologicals, because biologicals have a remarkable safety record, and we have biologicals now experienced for almost 2 decades worldwide. But the side effects can be substantial and unpredictable, because they are all immune directed. We direct the immune system against TNF, immune system against IL-6. There is always a potential for immune deviation and produce surprisingly very nasty, even autoimmune side effects with these drugs. And if you are prone for multiple sclerosis, it can precipitate demyelinating neuropathies and myelopathies. And we have to use these drugs on a long-term basis. All said and done, rheumatoid arthritis and other autoimmune diseases are long-term diseases. We are not going to cure them. So if you are thinking of using adalimumab upfront, and we need to probably consider using them on a long-term basis, in years, not in days or months. So it becomes economically unsustainable for most of our Indian population. And we had a fantastic idea some time back, whether we can use these drugs to induce remission, like cancer chemotherapy. Boom, boom, we put all the drugs get into remission and maintain with small dose of methotrexate. This has not been translated into a practically useful strategy because it has not been successful so far. And patients, many of our patients have comorbidities, diabetes, hypertension, ischemic heart disease, all have their own contraindications for biologicals. And there is always a small thought process whether these drugs would increase the risk of malignancy, because we all know that malignancy is kept in check by immune system. And we have known from oncology, the immunotherapy experience, like checkpoint inhibition promotes autoimmune diseases. So there is always a small use beyond many years, 10 years, 15 years, whether we would increase the risk. So far, biologicals database, it's reassuring. There is no increase in risk of malignancy with biologicals on at least 10 to 15 years follow-up. So where is the role for these drugs? In early rheumatoid arthritis, I have already alluded to, they are used only in situations where they are refractory, but they have a definite role in an established rheumatoid arthritis. Established is a rheumatoid arthritis of few years duration, where the autoimmune process has a deeper root into the system and very difficult to easily get into a remission. And aggressive early rheumatoid arthritis. There are patients who come to us very sick very early. These are the patients. And definitely we have a role to use this drug to achieve a remission. You try conventional disease modifying drugs, 3 months, 6 months down the line, the patients are not getting better. Use any armamentarium we have to achieve the target. And of course, we use rituximab in rheumatoid vasculitis, and we use these drugs in multi-DMRD. Inadequate responders are intolerant. If some people are unlucky patients, methotrexate they can't tolerate, sulfasalazine get allergy, leflunomide get liver problem, then we are left with no choice but to use etanercept or tofacitinib kind of a drugs. And this kind of situations we use monotherapy with JAK inhibitors like tofacitinib, baricitinib, tocilizumab, and etanercept. So this is a clinical scenario. A 40-year-old female, polyarthritis of 8 months duration, rheumatoid factor and CCP are strongly positive in high titer. Functional class 2, still the patient is working as a teacher and she still go to doing their activities. And should I use tofacitinib or biologicals? Probably no. These patients, we should give a trial of conventional disease modifying drugs like methotrexate plus or minus hydroxychloroquine. We can use small short course of bridge steroids and try to achieve a target. If you are not able to achieve a target with this aggressive approach, you reach from 15 mg methotrexate to 25 mg methotrexate over 3 months, and you added everything. At 6 months, the patient is not doing well. She will be a candidate for using biologicals or tofacitinib. Contrast this patient with the same 40-year-old another woman. Duration is 1 year. Rheumatoid factor CCP positive. She is already on 4 mg of prednisolone, and she has 20 swollen joints, 28 tender joints. She is dependent for most of her activities, and she is wheelchair bound. She is already on 10 mg methotrexate. Inadequately treated patient, like half-heartedly treated patients, 500 mg sulfasalazine, 10 mg methotrexate going on for 6 months, 1 year. Should I use tofacitinib or biologicals? Probably yes. I would probably very quickly optimize methotrexate, push the methotrexate to 25, give sulfasalazine 2 grams, and wait for 2-3 months maximum. If they don't do well, then quickly start them on biological DMRD or tofacitinib. And probably in certain situations, if I feel that that is not possible, or there's impending danger of very rapidly progressive disease, she might already have a flexion contractures, I would use these drugs upfront in this patient. Contrast this to spondyloarthritis, ankylosing spondylitis. The standard of care is non-steroidal anti-inflammatory drugs, physiotherapy in the early stages. Sulfasalazine and other DMRDs are useful predominantly in peripheral arthritis. When you have knee arthritis, ankle arthritis, probably they might work. When somebody has serious axial arthritis like inflammatory back pain, sacroiliitis, and they are unlikely to respond to conventional disease modifying drugs. Here we can use either anti-TNFs are IL-17 receptor antagonist and antibodies like secukinumab, ixekinumab or tofacitinib fairly upfront. This is one situation we won't hesitate, we won't wait and waste time with conventional disease modifying drugs because they are less likely to be useful in this clinical scenario. Psoriatic arthritis is another scenario where we might consider tofacitinib or biological injections upfront, because if you look at this algorithm, the peripheral arthritis still responds to conventional disease modifying drugs. We can treat them like rheumatoid arthritis with methotrexate, apremilast, sulfasalazine, leflunomide, etc. Then we go to biologicals only if they are not responding. And same for skin dominant disease. But when it comes to axial disease, dactylitis, enthesitis, these are the domains of psoriatic arthritis which is less likely to respond to your conventional disease modifying drugs. These are the patients who we would consider tofacitinib or anti-TNF like etanercept or infliximab, adalimumab very early. If they don't seem to respond within a month or two, we will quickly move to these drugs. Then what about SLE? Do we use biologicals in SLE? And the standard of care is still hydroxychloroquine, and the dose of steroid depends upon the severity of SLE. And we still use conventional immunomodulation like azathioprine, mycophenolate, methotrexate, cyclophosphamide for more serious diseases, and tacrolimus sometimes in a renal disease. This is the standard of care. And rituximab has been around in the lupus field for some time, and there are few observational data, and one exciting rituximab trial have shown its benefit. But randomized controlled trials 2009 Ka Explorer and 2012 Lunar studies have failed to show a benefit of rituximab over conventional drugs like mycophenolate in lupus nephritis. So, do we use? Yes, we still use. We can consider using this drug early. Early is not in the first visit, but very early. If you give them a steroid and taper the steroid to that 20 milligram, platelet comes down to 5,000. Then we know that, and you have already started them on mycophenolate. Mycophenolate is not able to control the decline in platelet count or in autoimmune hemolytic anemia, hemoglobin dropping down. Then we can consider using rituximab fairly early in the course of the disease, and we use it in a very refractory skin disease and in nephritis more as a rescue therapy after your standard of care like using cyclophosphamide or mycophenolate fail. And rituximab is a study, very interesting study. They used only rituximab and mycophenolate and steroid only during rituximab as a like 2 doses of steroid and no steroid with a fairly good results. But unfortunately, this type of studies have not been replicated. Until that comes, rituximab is still a second line drug in lupus. And there are other biologicals like belimumab and anifrolumab are still used as a second line therapy as of now. And in coming to vasculitis, giant cell arteritis is a rare disease in our country, but is a vision threatening and also life threatening if it involves large vessel vasculitis and causes aneurysms. And here steroid is still the drug of choice, but tocilizumab is an approved drug here, and because it occurs in elderly population with multiple comorbidities, tocilizumab could be considered very early in some of the patients to treat this disease. And ANCA vasculitis is like granulomatous GPA or what is called as a Wegener's granulomatosis and other microscopic polyangiitis. Rituximab is now upfront strategy. We can either use cyclophosphamide or rituximab as a first line therapy, and so this is one situation where we might consider using biologicals early. So not that biologicals should not be used early. There are definite indications for using it early. So to conclude, ladies and gentlemen, conventional disease modifying drug still remain the mainstay in initial management. I feel that it should still remain until we have 20 years data from tocilizumab and other biological drugs. And biologicals and other drugs like targeted synthetic game model like tofacitinib are an effective tool in our attempt to achieve treatment to target. So we have to use these drugs. Tofacitinib has become very cheap. it is being actually used as a first line therapy by non-rheumatologists, I will put it that way, because it works fast. But I feel that time is not yet right to start them as a first line therapy, and long-term effectiveness. We don't know how long tofacitinib is going to sustain its effect. At this moment, we have data for 10 years in tofacitinib. Some of the biologicals lesser than that. And safety is also a concern. And we have to select the patients appropriately as well. Patients, there's a lot of areas, elderly patients, patients with multiple comorbidities who have a high risk of coronary heart disease. We have had multiple patients, 35-year-old women with this tofacitinib developing myocardial infarction, which is extremely unlikely. So it has to be used carefully, and with powerful tools available, I think our responsibility also increases. And when somebody has an atom bomb, a president of US has got can press a button to initiate a nuclear war, and his responsibility must be the greatest responsibility in the world. I think Putin, in spite of his erraticity, he still has that wisdom not to press the nuclear war button. So it requires responsibility. So we need to skill to handle these weapons, and we need to acquire these skills before start using it. So my advice is, if you want to use these drugs, you have to learn about these drugs. And if you want to use methotrexate, learn a little bit about methotrexate. When we want to use tofacitinib, learn about contraindications, indications, then you will be better placed to choose the right patients. And there are few indications, like as I discussed, GPA and giant cell arteritis, biologicals can still be used as a first line, but in rheumatoid, it is still a part of it to target armamentarium rather than first line. But in spondyloarthritis and psoriatic arthritis, they still can be their first line therapy. Thank you very much.